Okay guys, we're going to go over the answers to this ROI practice PowerPoint that was posted for you. So let's jump right into question 1. Release of information without the patient's authorization is permissible in which of the following circumstances? A. Release to an attorney. B. Release to third-party payers. C. Release to state workers' compensation agencies. Or D. Release to insurance companies. Your best answer in this scenario is release to state workers' comp agencies. And so let's look back at the question. Release of information without the patient's authorization is permissible in which of the following circumstances? And so I'm going to point you back to your large handout of information. It's kind of weird. You know, it starts at the top, Chapter 8, Confidentiality Basics. And within that, there's some North Carolina information about state workers' comp. And so what you learned about state workers' comp in that handout is that, yes, we can, in the process of a workman's compensation claim, release a patient's record to that state agency for a report. D, I get a lot of questions about D most of the times, and include D because I just want you to know that insurance companies doesn't always mean to pay the bill. I want you to remember that people apply for life insurance, other different kinds of insurances where they need health information to determine what the health background of the patient applying for the insurance is for. Okie dokie. So question 2. Assigned consent for release of information dated 12/1/2015 is received with a request for the chart from the patient's admission of 12/5/2015. Indicate the appropriate response from the options below. A. Request another authorization that is dated closer but prior to the admission date. B. Request another authorization that is dated after the discharge date. C. Release the requested information. Or D, call the patient for a verbal authorization. All right, your best answer here is B, request another authorization that is dated after the discharge date. We're going to look again and see that the request for the chart from the patient's admission of 12/5. And so if the authorization is dated 12/1, that doesn't fall within this window. So if you've got a release of information dated 12/1/2015, you can only release information from this date and prior. So we're going to need B, another authorization that is dated after the discharge date. So we're going to take a look in our master patient index system, find out when this patient was discharged, and then request for the patient to send us a brand new signed consent that includes the dates of service that they actually want released. Okay, so question 3 says the minimum record retention period for patients who are adults discharged from acute care facilities is A, the age of majority, B, 5 years after discharge, C, 11 years after discharge, or D, the age of majority plus statute of limitations. The best answer is C, based on the state of North Carolina, 11 years after discharge. This is probably a review for you from HIT 114, last fall's class with Shannon, where you talked about record retention and record keeping policies. You guys talked about destruction of records, and prior to scanning, the ways that facilities were able to retain their records with microfilm and microfiche and all that kind of fun stuff. So why do we talk about retention when we're talking about release of information? Just because of this, right? So you've got laws that tell us how long we have to retain the information, but after that retention period is up, the facility is not required to hold on to the record. So if you receive a request from a patient that's older than 11 years for acute care facilities in the state of North Carolina, it's okay to not fulfill the request if the record has, been destroyed. So we can't actually fulfill it if we don't have the record to copy and provide to the patient. So nowadays, most facilities are certainly keeping their records for a lot longer, if not indefinitely. The storage mechanisms for EHRs are much better than paper-based records. So what you're finding now is that most facilities are keeping their records well beyond the retention rate. But this particular slide addresses acute care. But just a reminder, that you guys may not go work in acute care. You may go work in behavioral health or a long-term care facility. And from that standpoint, the retention period may be different. And those records are usually paper-based, unless they've got themselves aligned with one of the major systems. You're not going to find a lot of EHRs. So lots of different things to think about as far as retention and release of information are concerned. But here we're addressing acute care facilities 11 years after discharge. All right, so question 4 says, which of the following is a breach of confidentiality? A, a nurse speaking with the physician in the patient's room. B, staff members discussing patients in the elevator. C, the admission clerk verifying over the phone that the patient is in-house. Or D, the hospital operator paging code blue in room 3 north. So your best answer is going to be B, staff members discussing patients in the elevator. So this is a tried and true, and I just picked elevator when actually it could be cafeteria, it could be hallway, it could be anywhere within the facility that isn't a private area for staff members to be discussing. So let's bring up another concept that we've talked about before, which is scope of work. And just remember that we shouldn't be gossiping about patients or what we've read or what we've seen among staff members. We should only have access to the patient's protected health information within the scope of our job. So if it's not within the person's scope that you are speaking with, then actually what is happening is that you are releasing information improperly. So some of your assignments have dealt with access of healthcare providers and whether doctors should have the right to access because they're a doctor. And most of the time you guys answer that correctly, that no, just because we work in healthcare doesn't mean that we have access to it. It's got to be within the scope of our work. A physician has to be treating the patient to be able to see what's going on in the record. And so if you guys can just remember scope of work, that's really going to help you understand at what point a healthcare provider has the right to a patient's PHI. Okay, question 5. Which of the following is true of the Notice of Privacy Practices? A, it gives the CE permission to use information for treatment purposes. B, it gives the CE permission to use information for TPO purposes. C, it must be provided to every individual at the first time of contact or service with the CE. D, it must be provided to the individual by the CE within 10 days after the receipt of treatment or service. C, it must be provided to every individual at the first time of contact or service with the CE. And I'm going to point you back to your HIPAA handout. Remember that that handout that had a lot of HIPAA information on it that was numbered. So you will find that when you look through the information that talks about the Notice of Privacy Policies, that we're required to provide every individual at the first time of contact or service with the CE. And then annually, you're going to ask your patients to update that, their signatures, that they've read it, they've seen it, and do they have any questions? Question 6. Which of the following statements is true about the directory of patients maintained by a CE? A, individuals must be given an opportunity to restrict or deny permission to place information about them in the directory. B, individuals must provide a written authorization before information can be placed into the directory. C, the directory may contain only identifying information such as patient's name and birth date. Or D, the directory may contain private information as long as it is kept confidential. So your best answer is A. Individuals must be given an opportunity to restrict or deny permission to place information about them in the directory. Upon admission, your patients are asked whether or not they want to be listed in the directory, and the types of information that we give out when a call is made to a facility about a patient should be reviewed with the patient. So the person that is doing the triage or the intake should discuss with the patient what information would be listed should an inquiry be made to the hospital about a person within the facility. So your patients have a right to deny that, and if they do not want to be placed in the directory, then they're not placed there. We mask where they are or hide that information to people who shouldn't have access to it. Again, scope of work. That doesn't mean we've lost them in the facility. There are people who actually know where they are and can see that level of privacy, but what that would mean is that you're just average individual, usually volunteers working the desk, providing information about patients who are staying in the facility would not have access to that. Question 7. What does the abbreviation PHI stand for? Is it A, personal health information, B, protected health information, C, primary health information, or D, past health information? And your answer is B, protected health information. I get a lot of questions about, will you have questions like these on the exam? These types of questions, what does an abbreviation stand for, are few and far between. I will use actual abbreviations within questions that you have to understand what the abbreviation is to be able to answer the question correctly. For example, if we pop back up to question 6, when I talk about CEs, that's a great example that you would have to know what a CE is to understand what that question meant. So protected health information, we all know what that is. It's the patient's private protected information, and it's subject to all the rules of disclosure from HIPAA and state law. Okay, question 8. Under HIPAA rules, when an individual asks to see his or her own health information, ACE, A, must always provide access, B, can deny access to psychotherapy notes, C, can demand that the individual pay to see his or her record, or D, can always deny access. B is your best answer. Can deny access to psychotherapy notes. So, HIPAA provides for patients to be able to have access to their own information. But there are certain situations, and behavioral health notes, psychotherapy notes, where a facility and a physician can withhold the information when they deem it may be detrimental to a patient's course of care or to their health. So they get that therapeutic privilege to be able to do that, and HIPAA protects them from that. And so what that means is that typically if you're going to get a request from a patient to see their own health information, and within that request that you discover that there are behavioral health or psychotherapy notes, what you would in turn then do is turn that request over to the physician so they can make the determination on what happens with that request. And there's a few ways that can play out. The first way is that the physician can just say yes, absolutely, the patient can have access to the notes that they are requesting. The next thing they can choose to say is no, the patient may not have access to that information, and they can provide a reason why, and then that's provided to the patient. And then the next choice that they have is really a hybrid of the two. Yes, the patient can have access, but they have to have the access with me so I can explain to the patient what they're reading. And so those are 3 good examples of how a physician may handle a request for psychotherapy notes. And I'm going to pause here at slide 8, and then we'll pick up in the next recording.